This program is brought to you by Emory University.
Good morning. Welcome to Cardiology Grand Rounds, Cardiovascular Grand Rounds. I understand this is our last Grand Rounds of the year, Pooja tells me. It's a pleasure for me to introduce our Grand Round speaker, who's a good friend and a colleague. Joo Myung Lee is assistant professor at Samsung Medical Center in Korea. And we have the privilege of having him as a visiting scholar at Emory this year. Joo Myung let me first tell you, he's going to talk to us today about how can we predict ACS occurrence in the future beyond stenosis, vulnerability, and ischemia. As you know, this topic is a topic that we've struggled with and grappled with for the last 2 decades. And right now, with all the conversation with ischemia and CT angiography, it's a very, very hot topic. Joo Myung has been embedded in this field for the last 10 to 12 years. He's one of the most outstanding clinical investigators and interventional cardiologists right now, I think, around the world. He's published extensively in this field. Many of his papers are widely quoted in the guidelines and help shape the European guidelines and are also quoted in our guidelines. So I'm really excited to hear about the work that you've been doing and how it ties into predicting stenosis, vulnerability, and ischemia. Joo Myung, welcome.
Thank you so much, Dr. Samadi. Yeah. Hello, everyone. I'm Joo Myung Lee from Korea. Yeah, I'm not a native English speaker, but I will try my best. And thanks for the nice introduction, Dr. Samadi. And we've been collaborating since 4 years ago, and I'm an interventional cardiologist in my hospital, and I'm here for 1 year sabbatical, and I'm currently working with Dr. Samadi. And I've been interested in coronary imaging and physiology, and also have huge interest in biomechanical force and developing some prediction algorithm for the future acute coronary syndrome. So I will talk about this subject and show you some future possibilities using new approach to predict acute coronary syndrome. So let me introduce one of my patients first. This 69-year-old gentleman presented with asymptomatic status, but some abnormality in his coronary CT angiography. And this was 6 years ago. At that time, his stress echocardiography was negative, and exercise capacity was excellent, and no symptom at all. But his coronary CT angiography showed multiple intermediate stenosis in LAD and RCA. So I prescribed the statin and aspirin as a primary prevention, but unfortunately, about 4 months later, he came to our ER. He had acute chest pain and cardiac enzyme elevation, and in ECG, there was ST depression. So with the diagnosis with non-STEMI, I did the coronary angiography, and which showed near total occlusion at the proximal LAD. So at that time, I've asked myself, does the conventional testing works very well to find patients at higher risk? And how can we develop some nice algorithm to find this kind of patient? So as you well know, the recent ischemia trials showed no additional benefit of invasive treatment over medical treatment alone in stable patients with moderate to severe myocardial ischemia. To me, the real problem is not the PCI or bypass surgery. Might be the real problem is the conventional ischemia testing plus coronary CT angiography might not work very well to find the patient at higher risk of future clinical event. So let's consider about the mechanism of plaque rupture and acute coronary syndrome. In general rule of material failure, plaque ruptures occur whenever hemodynamic stress exceeds the plaque durability. So in order to assess the risk of plaque rupture and acute coronary syndrome, the 3 information should be evaluated. the plaque vulnerability and external or internal plaque structural stress and interface between hemodynamic stress and plaque rupture, which is the plaque geometry. So my talk will be the fourth part, and let me start with the first part of the presentation. In this part, I will talk about current paradigm of anatomic vulnerability and its limitations, and metabolic vulnerability assessed by sodium chloride PET as a promising tool. So the current assessment of risk stratification has been mainly focused on the anatomic vulnerability using invasive or non-invasive imaging modalities. And the landmark studies such as Prospect, Arterimo, and Viva studies consistently showed the VH thin cap fibroateroma and high plaque burden and narrow lumen less than 4 square millimeters was associated with future acute coronary syndromes. However, this invasively assessed anatomic vulnerability showed low positive predictive value, and of course, its cost effectiveness was not evaluated. And recent studies using coronary CT angiography also showed similar result. In ROMICAT 2 trials, the stenosis over 50%, positively modeling low attenuating plaque, napkin ring sign, or spotty calcification was the independent predictor of future ACS. And Dr. Motoyama's study from Japan, she evaluated the significantly higher risk of future ACS in patients with positively modeling and low attenuating plaque. But this non-invasive assessment anatomic vulnerability has also similar problems. In Dr. Motoyama's study, only 9% of lesions showed high-risk plaque features in patients who underwent coronary CT scan, and among these high-risk plaques, only 15% were related with future acute coronary syndrome. So this type of approach has consistently low positive predictive value to predict future event. So the reasonable question might be, can we enhance the predictability of future event? So recent studies using sodium chloride PET showed promising result. The sodium chloride preferentially bind to developing microcalcification and localized activity in coronary plaques, suggests the most active stage of vascular inflammation and microcalcification. This very important study from UK by Dr. Mark Dweck, they evaluated STEMI and non-STEMI patients, and all patients underwent sodium chloride PET in comparison of tissue background ratio between culprit and non-culprit lesions. As you can see, the culprit lesions showed about 34% higher tissue background ratio than non-culprit lesions. So at that time, I thought that if sodium chloride PET can detect metabolically active plaque in stable patients, this might be the key element to build up some prediction model for the future ACS. So these patients were 61-year-old gentlemen and presented as stable angina, and angiography showed about 70% stenosis in the medial AD. In the IVUS, the plaque showed extreme positive remodeling and posterior attenuation, suggesting very high-risk features in IVUS. And OCT also showed similar findings of high-risk features, including thin cap fibroateroma and prominent microvessels and macrophagy infiltration. In sodium chloride PET, the medial AD plaque showed strong positive uptake. So using the tissue background ratio, sodium chloride PET can provide mild, moderate, and marked uptake at the coronary atherosclerotic plaque. And as you can see, these PET findings are well correlated with CT, IVUS, and OCT-related plaque features. So we designed the prospective registry, and exclusively evaluated non-MI population. All patients underwent the sodium chloride PET and also evaluated by invasive imaging using IVUS or OCT, and part of the population were also evaluated by coronary CT angiographies. When we compare the angiographic stenosis severity between positive and negative uptake plaque, there was no significant difference. However, the PET positive plaque showed higher absolute and relative amount of the plaque. And in comparison of vulnerable features between positive and negative plaques, the sodium chloride PET positive lesions showed higher incidence of positive remodeling and posterior attenuation in the IVUS, and in the OCT, the positive plaque showed higher maximum repeat arc than negative plaques. So in order to compare the invasively assessed plaque characteristics, we classified all the lesions into 3 groups. The group 1 showed none of high-risk features in both IVUS and OCT. Group 2 showed at least one high-risk features in either IVUS or OCT. And group 3 was the most vulnerable group, and high-risk features were present in both IVUS and OCT. As you can see, the tissue background ratio was the highest in the group 3, and over 90% of the lesions in group 3 showed positive PET uptake. And this is interesting result. And in regions with none of high-risk characteristics, only 5% of lesions showed positive PET uptake. However, in regions with any of high-risk characteristics in IVUS or OCT, over 94% of lesions showed PET positive uptake. And in comparison of diagnostic accuracy between CT-derived adverse plaque characteristics and PET uptake, only 44% of lesions in group 3 showed the CT-derived adverse plaque characteristics. However, all of the lesions in group 3 showed positive PET uptake. Recently from Japan, they presented the prognostic implication of sodium chloride PET. In their report, the patient with higher tissue background ratio in sodium chloride PET showed significantly higher risk of cardiac death, acute coronary syndrome, and late coronary revascularization than those with low tissue background ratios. So let me summarize the first part of the presentation. And current paradigm of anatomic vulnerability has limited positive predictive value for future clinical event, and sodium chloride PET can detect metabolically active high-risk plaques. And it can be a useful non-invasive tool to identify and localize high-risk plaque in patients with coronary artery disease. And in the future, the non-invasive tests which integrate both anatomic and metabolic vulnerability will enhance the predictability of future clinical events. And in the second part of my presentation, I will talk about the current paradigm of FFR-guided strategy and its potential limitations, and clinical meaning of plaque vulnerability in our FFR-guided decision. So although the previous researches used plaque vulnerability to stratify the high-risk plaque, however, our current practice has not been guided by plaque vulnerability. It was mostly guided by the hemodynamic vulnerability using FFR or IFR. The FFR-guided PCI strategy has proved its benefit over NGO-only guided PCI in multiple randomized trials. This slide is famous FAME2 trial result. As you well know, FAME2 trial randomly allocated patients with positive FFR into the medical treatment group or medical treatment plus PCI group. And any patient with negative FFR was followed as a registry group. When we focus on this registry group, about 16% of patients developed clinical event despite the negative FFR. So what would be the cause of the cardiac event in patients with negative FFR? As the current guideline recommend PCI for the regions with positive FFR, it is very important to understand the potential cause of clinical event in negative FFR population. I've been working on this subject during the past 6 years and published papers about clinical meaning of each component listed in here. Among the potential cause, maybe the plaque vulnerability is one of the major cause of clinical event in FFR negative patient. So clinically relevant question in daily practice might be, is there any relationship between anatomic and hemodynamic vulnerability? And if it is this yes, and what will be the mechanism? And is there any prognostic implication of anatomic vulnerability in current FFR-guided strategy? So for these questions, my group recently evaluated the prognostic implication of CT-derived high-risk plaque characteristics in patients treated by FFR guidance. So for this, we used 3-vessel FFR French registry data. In this study, about 1,100 patients were evaluated by routine 3-vessel FFR measurement regardless of stenosis severity, and main results were published in European Heart Journal a few years ago. Among the total patient population, we selected about 300 patients who underwent coronary CT scan within 3 months before invasive angiography. And the FFR tracing was independently validated in physiological lab, and CT was analyzed in the Dr. H.J. Zhang's core lab, who was also core lab of the confirmed registry. And for the clinical outcome assessment, we used vessel-related 5-year clinical outcome data. As I presented before, the landmark studies consistently presented the plaque burden and minimal lumen area was also very important determinant of future event. And in atherolimo IVUS study, the VH-DICPAR without the high plaque burden did not show any prognostic impact. So this result means quantitative morphology is also very important determinant for the future event. So in this study, we used the 6 individual criteria of both quantitative and qualitative indices using coronary CT scan. So using these 6 individual criteria, we can calculate the number of high-risk plaque characteristics, and for the 5-year vessel-related outcome, the C-index of the combined criteria was much higher than the individual criteria. When we see the relationship between number of high-risk plaque characteristics and per vessel FFR, we can clearly see the negative association in higher number of HRPC and lower the FFR. And when we compare the regions with 3 or more high-risk plaque characteristics by range of FFR, we can see the proportion of high-risk plaque characteristics were much higher in lower range of the FFR. This result means lower the FFR, the higher chance of high-risk plaque characteristics. So what will be the mechanism of this relationship? So today, the Walsh stress theory has been a fundamental explanation in plaque initiation, progression, and transformation into more vulnerable phenotypes, including Dr. Samadi's representative manuscript. Low Walsh stress has dual actions. The low Walsh stress mainly related with plaque initiation and progression, but high Walsh stress was related with the plaque transformation into more vulnerable phenotypes. Recent study from UK nicely demonstrated the role of wall shear stress and plaque structural stress. In their study, low wall shear stress was the determinant of the plaque progression, and high plaque structural stress was related with compositional change with increased necrotic core. So we can consider this kind of the explanation. Hemodynamic stress distribution determine the plaque initiation and progression, and when the anatomic stenosis occurred, this stenosis caused pressure gradient, and this pressure gradient further changed the distribution of hemodynamic stress, including increased wall shear stress and increased plaque structural stress. And this wall shear stress and plaque structural stress transform the plaque composition into more vulnerable phenotype, and high pressure gradient manifested by positive FFR in our clinical practice. So is there any additive prognostic impact of anatomic vulnerability in our FFR guidance? When we see the association between FFR and the risk of vessel-related event, we can clearly see the negative association of higher the FFR, lower the risk of vessel-related event. And number of high-risk plaque characteristics also showed significant relationship with the risk of vessel-related event. And in the regions with 3 or more high-risk plaque characteristics, we can see the risk of clinical event was much higher than regions with low number of high-risk plaque characteristics. So in comparison of the risk of vessel-related event between 3 or more high-risk plaque characteristics with the other one, the regions with 3 or more HRPC showed about 4 times higher risk of vessel-related event than the low number of high-risk plaque characteristics. In this cohort, the risk of vessel-related event in the regions with low FFR and PCI was about 10%. As expected, most of the regions with negative FFR showed much lower risk of vessel-related event. However, in the regions with negative FFR, deferred revascularization, but higher number of high-risk plaque characteristics, the event rate was higher than the revascularized regions. This result means the plaque vulnerability might be the key to understand the clinical event in negative FFR patient. So let me summarize the part 2. There are complex associations among stenosis severity, vulnerability, and FFR. Some plaques with 3 or more CT-defined high-risk plaques can show higher event rate despite negative FFR. However, none of stenosis severity, anatomic vulnerability, or FFR can fully explain who will occur future adverse clinical event. All these parameters are just surrogate markers, and we need more information to find patient at higher risk of future event. So in next part, I will introduce some role of hemodynamic stress beyond the FFR and its relationship with lesion geometries. This very interesting study published 20 years ago, they evaluated the situation of sudden cardiac death and the autopsy findings. In patients who suffered sudden cardiac death during exercise, the main pathology was plaque rupture. However, in patients with sudden cardiac death during resting, the only 23% of lesions showed plaque ruptures. And another interesting study from Japan, they compared the cap thickness of the culprit lesions between exertion-triggered ACS and rest-onset ACS. In their report, the cap thickness was much higher in patients with exertion-triggered ACS. And this result strongly suggests the important role of hemodynamic stress in plaque rupture phenomenon. And let's see the FAME2 result again. In the medical treatment group, although all the patients were positive FFR, but the event rate was only 27% at 5-year follow-up. This means 73% of patients with positive FFR were just okay. To me, it is kind of natural because FFR or even recent resting indices are just one aspect of hemodynamic vulnerability. In coronary circulation, there are numerous aspects of fluid dynamics, and FFR or IFR is just one surrogate marker of this coronary flow dynamics. So clinically relevant question might be additional consideration of other hemodynamic parameters will enhance predictability of future event. So let's go back to the role of wall shear stress. The wall shear stress, its magnitude is generally very small, but it is very important, and the very high wall shear stress, more than 30 dyne per square centimeter, were known to be related with vulnerable transformation and platelet activation. And the role of high wall shear stress in subsequent myocardial infarction was recently demonstrated by Dr. Samadi's team. They focused on the medical treatment group of FAME2 trial and selected 28 patients with propensity score matched group. This figure demonstrates the striking difference in wall shear stress, even though both patients had same FFR value of 0.71. In left patient, the wall shear stress across the proximal LAD stenosis was very high, but in right patient, the wall shear stress was very low. The only left patient occurred LAD-MI about 1.5 years later, but in right patient, there was no clinical event during the 3 years of follow-up. So, and the high wall shear stress was related with significantly higher risk of subsequent myocardial infarction in low FFR groups, and adding the wall shear stress also showed significantly higher reclassification ability for the subsequent myocardial infarction. But I would like to say wall shear stress might not enough to explain the plaque ruptures. Let me show you one of my patients. This patient presented with atypical chest pain. In the coronary angiography, there was about 70% stenosis in the left main, and FFR was 0.66. Of course, I did the PCI for the left main, but the interesting part, when we see the longitudinal IVUS cross-section images, the plaque rupture was occurred at the downstream segment. As the blood flow is always anterograde direction, how downstream plaque rupture can be possible? So that was my main curiosity at the time. But downstream rupture is not the rare phenomenon. This very interesting study from Dr. Akasaka's group, they evaluated the location of plaque rupture from patients with STEMI or non-STEMI and unstable angina. The incidence of downstream rupture was about 36%, and the pressure drop mainly occurs at the upstream segment of the plaque. This cannot explain the occurrence of the downstream ruptures. And wall shear stress is generally too small to act as a direct force to break up the plaque cap of the atherosclerotic plaque. For example, the pressure gradient of the 10 millimeter mercury is about 130 dyne per square centimeter, but general magnitude of the wall shear stress is 10 times lower than the pressure gradient itself. So why do we have to care about downstream plaque ruptures? Because the clinical presentation and patient prognosis is very different according to the plaque rupture locations. So as with the previous Japanese study, my study also presented the proportion of patients with acute myocardial infarction is much higher in upstream ruptured plaque. But the downstream ruptured plaque is usually presented with non-STEMI or unstable angina rather than STEMI. So in this regard, we consider the concept of axial plaque stress. The total traction acting on the plaque can be expressed in the two ways. In relation to lumen surface, the total traction is the function of wall shear stress and pressure. However, in relation to the vessel center line, it can be expressed as a function of axial plaque stress and radial plaque stress. So as you can see in this cartoon, the wall shear stress is the green line and axial plaque stress is the blue line. The axial plaque stress is much larger than wall shear stress, and it can uniquely characterize the upstream segment and downstream segment of the coronary stenosis. And the axial plaque stress is the axial component of total traction. It can be also expressed as the pressure and the radius gradient. The radius gradient is the change of vessel radius over segmental region length from region start to the MRA and MRA to the region end. So to validate this concept, first we created idealized stenosis model. These two types of stenosis has same diameter and same stenosis severity, but different longitudinal geometry. In upstream dominant regions, the upstream radius gradient was higher than downstream segment, but in downstream dominant regions, the downstream radius gradient is higher than upstream segment. As this stenosis has same stenosis severity, the FFR same, and wall shear stress, its distribution is same. However, the axial plaque stress, only this can discriminate these two types of stenosis. In the upstream dominant regions, the upstream axial plaque stress was much higher than the downstream segment, but the downstream dominant regions, downstream axial plaque stress is higher than the upstream segment. And we thought this axial plaque stress distribution might be the key to explain the downstream rupture and the location of plaque ruptures. After validating this concept, we evaluated the real patient-specific stenosis models. And all these stenoses were classified by upstream dominant and downstream dominant regions. Two types of stenosis show the same FFR, same diameter stenosis, and same distribution of wall shear stress. And wall shear stress was always higher in the upstream segment, regardless of the longitudinal region geometry. Only the distribution of axial plaque stress can explain this different type of longitudinal region geometry. After that, we evaluated the real ruptured plaque, and all these regions were confirmed plaque rupture by IVUS and OCT. In upstream ruptured plaque, the upstream radius gradient was higher than the downstream radius gradient, and while downstream ruptured plaque, the downstream radius gradient was higher than the upstream segment. And using this, the real patient-specific stenosis model, HeartFlow did the computational flow dynamics, and in the upstream ruptured plaque, the upstream axial plaque stress was higher at the rupture location, but the downstream ruptured plaque, the downstream axial plaque stress was higher than the upstream segment. And the wall shear stress has much lower magnitude, and the upstream wall shear stress was always higher than the downstream segment. So when we see the relationship of the region length and the distribution of axial plaque stress in various the severity of the stenosis severity, there is inverse nonlinear relationship with the region length and the distribution of axial plaque stress. And this means the short focal regions were exposed to the higher magnitude of axial plaque stress, and it might be explanation for the why focal stenosis is more prone to be ruptured than the diffuse regions. And when we see the stenosis severity and the axial plaque stress, the distribution, the upstream axial plaque stress represented by blue bar, it showed the linear relationship with the stenosis severity. However, the downstream axial plaque stress represented by red bar, you can see the dual response to the lesion severity. This means when the stenosis severity was higher than 60% of the stenosis, the downstream axial plaque stress was lower. And this means downstream rupture is prone to be occurred in less severe stenosis, and it might be the reasonable explanation why patient with downstream rupture usually shows less severe clinical presentation and less frequent TIMI-0 flow in the culprit vessels. So we can summarize the role of wall shear stress and external force like this. The high wall shear stress usually act as a trigger of plaque vulnerability and platelet activation. However, in order to break the atherosclerotic cap, we need external force, and the distribution of this external hemodynamic stress is determined by region geometry. So let me summarize the part 3. The FFR is just one aspect of hemodynamic vulnerability, and it is insufficient to find patients at higher risk, and additional hemodynamic stress such as wall shear stress, plaque structural stress, and axial plaque stress might be the key to understand the plaque rupture phenomenon. So now let's move on to the last section of my presentation. Based on the previous presentation, I will talk about the integration of stenosis, vulnerability, and hemodynamic stress to predict future ACS. So the real question is that how can we build up some prediction model for the future ACS? So using the conventional and new parameters, we designed the Emerald study. How can we build up this kind of prediction model? Given the low incidence of acute coronary syndrome, if we try to design prospective study, we may need 5,000 patients and 10 years of follow-up. So we sought some unique design of the Emerald study. First, we searched the patient with confirmed acute coronary syndrome by angiography from 11 international cardiovascular centers from 5 countries. Then we've searched patients who had underwent coronary CT angiography before ACS event. And using the angiographic images, we validated the location of culprit and non-culprit regions and analyzed CT for the plaque characteristics and hemodynamic stress. Each component of information was validated in 3 independent core laboratories, and CT plaque characteristics were analyzed in CT core lab, and hemodynamic stress were analyzed in the heart flow, and the location of culprit regions were validated in angiographic core lab. And the enrolled patients were general population of cardiovascular disease, and over 93% were presented with acute myocardial infarction, and minority of patients were unstable angina with confirmed plaque rupture in IVUS and OCT. And over half of the culprit regions were located in LAD, and most culprit regions were intermediate stenosis with FFR-CT of 0.77. And for the plaque characteristics, we used well-known parameters. And for the hemodynamic stress, based on our previous researches, we considered 4 parameters. And the delta FFR-CT means the FFR gradient across the target stenosis. So in order to classify the regions into high risk or low risk group, we use the cutoff value of each hemodynamic stress. And it is interesting that the cutoff value of FFR-CT for the future ACS was 0.80, and the Warsaw stress was 150 dyne per square centimeters. When we compare the stenosis severity, plaque characteristics, and hemodynamic stress between the culprit and non-culprit regions, the culprit region showed higher stenosis severity, longer region length, and worse profile of plaque characteristics, and worse profile of hemodynamic stress. So the main question was is there any additive value of hemodynamic stress in predicting future ACS? So we built the 3 prediction models. The model 1 was diameter stenosis plus region length, and model 2 added the adverse plaque characteristics into the model 1, and model 3 integrated the stenosis severity, region length, plaque characteristics, and hemodynamic stress. As you can see, the model 3 with the hemodynamic stress showed highest C index and increased reclassification ability for the future ACS. And among all the variables, the delta FFR-CT showed the highest information gain to explain future ACS. And when we classify all the regions by the distribution of adverse plaque characteristics and adverse hemodynamic characteristics, the regions with both APC and AHC had 11 times higher risk of the future ACS. And among the regions with both APC and AHC, about half of regions were related with the culprit regions. So this type of approach has much higher positive predictive value for the future ACS. So now let's go back to our first case. To remind you, this patient was asymptomatic and showed multiple intermediate stenosis in the CT, and 4 months later, he visited as a non-STEMI patient. And when we apply the Emerald concept, both LAD and RCA was FFR negative lesions. However, in the LAD, there was adverse plaque characteristics, and hemodynamic stress profile was also very bad. And it became a culprit region of non-STEMI 4 months later. But the proximal RCA plaque, there was minor adverse plaque characteristics and none of adverse hemodynamic characteristics, and remained as a non-culprit at the time of the acute coronary syndrome. So of course, the Emerald 1 was a proof of concept study. Now we are planning for the Emerald 2 study with similar study design, but much larger sample size. And in the Emerald 2, we will also use the external control group from advanced FFR-CT registries. To date, about 30 international cardiovascular centers are joining to Emerald 2 study, and more sites are joining now. So let me conclude my presentation today. I personally believe the integration of the stenosis severity, myocardial mass, and anatomic and metabolic vulnerability, and the hemodynamic stress might be the key to predict patients at higher risk of future event. And in someday, of course, this is my dream, we may be able to make our clinical decision not based on the surrogate marker, but based on the predicted risk of the future event. So this type of the predicted risk-based decision might be able to in the near future, and it is my dream. Thank you for your attention.
Okay, that was a really great talk. I enjoyed it. Any questions from the audience? Spencer? I think you're trying to get the microphone to kick in here. Let me get another one.
Well, that's a fantastic talk. I mean, that's extremely exciting. Very seldom do we see all these things integrated. The sodium fluoride, is that, what is it? Is that identifying inflammatory cells, or what does sodium fluoride do?
Yeah, the sodium fluoride is preferentially bind due to the calcium phosphate in the atherosclerotic plaque. So the positive uptake means there is calcifying activity in that plaque. So it can detect early stage of the vascular inflammation, especially with the microcalcification.
So your ultimate dream, does this depend on eventually machine learning of all these things and then putting them all together? You get and we just
Yeah.
get a CT-based study and we know everything?
Yeah, maybe in future, just outpatient clinic, they do the CT and get to CT plus sodium fluoride PET or something. We can get the many covariables in the deep learning models. And after some learning the deep learning model, we can see the individual risk of each plaque. So we don't have to measure FFR or something just to see the result. Wow, that proximal LAD plaque has high risk of future clinical event. So do the perfect PCI in the cath lab. So maybe that's possible in the future.
Yeah, I think it's a really interesting time to talk about this because I could see if you think who's been really focused on the ischemia trial, which has kind of been one of the biggest studies that have come out this year, and this whole concept of what are we trying to achieve in stable ischemic disease, right? I think the consensus is if you can make people's symptoms better, just like you might do for an orthopedic procedure, you might get rid of their angina, then we would all agree that revascularization, even the ischemia study, showed that. So I guess my question to you is when you're assessing a patient clinically, you know, to me, there are these two paradigms. They're, okay, symptomatic patient, you're trying to improve their quality of life, but then what you're getting at and what several groups have been interested in is even in the stable patient, is there a way to really get into that high-risk prediction model, which then could be addressed for either pharmacologically or mechanically or both. So how do you apply this to you see a patient in clinic who may have, you know, shortness of breath on exertion and, you know, may have mild to moderate ischemia, and you do a CTA, which of those pathways do you go down? Do you focus on their symptoms, or do you focus on trying to identify if they're high risk, and then how do you approach it? How do you see this moving forward?
Yeah, that's a very good question. And actually, I'm trying to be a good physician. So that means I cannot ignore the current guideline. So my main practice were just like the usual practice guideline, but using this concept, we can warn the patient and give patient about the information. So based on I usually tell my patient, so based on my research, your CT scan showed some high-risk features. Even though FFR was negative, you should stick to the medical treatment. And usually I let the patient write some exercise diary. So do the regular exercise. Doing the regular exercise might be the free treadmill test in your daily life. So if you feel some strange feeling, please call me or visit my office. And I usually do some follow-up CT scan and follow-up sodium fluoride PET after some intensifying the medical treatment. So sometimes I see the positive PET uptake is disappeared after high intensity statin treatment. So maybe that steps are the gathering information to build up the further prediction model.
So once upon a time, Mike Gravanis, I heard him say that they see ruptured plaques a lot, and all ruptured plaques don't lead to occlusion. Have you got a concept about that?
Yeah, so maybe you can remember the downstream ruptured plaque. So downstream ruptured plaque usually do not show any total occlusion of the target vessels. Usually the upstream ruptured plaque has higher possibility of the flap can block the blood flow than presented with total occlusion and thrombus on top of the plaque. But the MLA rupture or downstream rupture has low possibility of the blockage of the target vessels. I think that depends on the fluid dynamics through the ruptured plaque. So that's why it is important to assess region geometry and possibility of the plaque rupture and which location the plaque will be ruptured. If we can predict that possibility, that might be the key to find some high-risk patient, and we can even do the preemptive treatment in the future.
So then the next step will be to try to identify the high-risk ones and then drop their LDL to 30 with Repatha or Preluent and try to modify the clinical course.
Yeah.
Now, my understanding is, Habib, I don't think we have this modality here, do we?
You mean
The CTA and the hemodynamic. Do we have that available?
So we have CTA available.
I know that.
We
Yeah.
don't have the hemodynamic parameters. We currently don't have.
But we're on the verge
but-
of having them,
Huh?
or are we? Are
Yeah,
on the
we're working to get that. I know that Arthur Stillman and others in the imaging world are trying to do that. Currently, the clinical tool provided is CT-FFR, which really focuses on the hemodynamic paradigm, right? You know, are you symptomatic? Do you have a positive lesion? Do you need revascularization? I think some of these other parameters that Joo Myung and frankly in our lab we're studying are still kind of research parameters, but could very easily be integrated into a CT platform. I mean, that's, but the sodium fluoride's kind of interesting. There was a lot of excitement about sodium fluoride a few years back with the study by DeWick's group, which you could then non-invasively risk stratify a patient from a metabolic perspective, as well as a hemodynamic and a biomechanical one. So I think the field is moving. And we are making progress. And I think that most interventionalists are sort of thought of or accused that we're always trying to enrich a population that we can then preemptively go and stent, right? We're always trying to do that. And the truth is that there may be a component of that, but with improving anti-atherosclerotic therapies that are really expensive, as Dr. Clemens says, you know, the question is, do you have an enriched group that you might say, you know what, your LDL targets might be different, right? Do you get more aggressive? And then Arshad's not here, but obviously the whole sort of inflammatory oxidative stress components of the risk come in terms of biomarkers. So you can imagine a situation where, you know, he's done this great work with biomarkers. You have an enriched person from a biomarker perspective. They're inflamed, they have oxidative stress, et cetera. And then you add to that the metabolic component. and then you add to that the hemodynamic and the plaque component, and then potentially you have a very enriched group. Pooja?
Hi, great talk. I have two questions for you. One is I want to know your thoughts about the Minoka population. So, no obstructive disease and troponin leaks, whether this could help us. And the other thing is your sudden cardiac arrest data that you showed that was old. The one thing that's not being addressed here is sympathetic dysfunction, right? So is there a way to integrate MIBG or some other sympathetic measure, and maybe that would help the prediction model?
Yeah, that's a great question. Actually, the minocar and the sympathetic activation might be related. And all these my talks were for the atherosclerotic plaques with measurable amount of the plaque burden. But in minocar, if this similar process of acute myocardial infarction was happened, but there was minimal amount of the plaque, that plaque cannot cause the total block of the blood flow through the target vessel or very serious event. I think the minocar is type of MI which occurred in very small amount of the plaque. So maybe this concept, the delta FFR, wall-shear stress, APS, and sodium chloride PET cannot apply into the minocar patient because there is no measurable plaques in the culprit region. So I think that is the totally different type of the patient.
Yeah, so to that point, I mean, there's a lot of interest in endothelial function and the microvasculature and the interplay between that and Minoka patients. You've done a lot of work in that, and I think that's sort of a complementary paradigm that needs to be explored. Any other questions? Well, with that, then let's thank you for a great talk.
Thank you so much.
The preceding program is copyrighted by Emory University.